So podiatry is a specialist field. We come under an umbrella of allied health professionals like physiotherapists and nurses, midwives, paramedics. They all come under the same. We're all regulated by the HCPC, and podiatry is to do with the lower limb. So we are specialists in managing all things from the hip down. Now, typically, we tend to be a bit better at foot and ankle because that's what people come and see us for the most, but we are qualified and we are insured from the hip down, and I think that's something that most people don't necessarily realise. So who's it for? Well, everyone really. The service that we're going to be offering at Move4 is more specialist towards musculoskeletal. So basically, if you've got pain in the lower limb, then podiatry is for you. We can look at it, we can assess it, and we can give you our sort of lower limb centric perspective on what might be causing that pain, and work together to get you better. We see all manner of musculoskeletal complaints. Try saying that 3 times fast, eh? Over the last sort of 12 years now that I've been qualified, I've seen lots of weird and wonderful things. Most of the things that we see are sort of plantar heel pain, so pain underneath your heel, or retrocalcaneal heel pain, pain in the back of your heel. We see lots of forefoot pain, medial ankle, lateral ankle, shin pain, knee pain. I've seen quite a lot of varied presentations with this. So some of these will be like bone stress injuries and more sort of bony issues and load induced pathologies. Some of these will be nerve issues. Some of these will be tendons, muscles. Some of it is to do with like the joint itself and some of the mechanics there, and some of the way that people move kind of informing that, and we can modify, tweak and look to again sort of deload these things and get you better. Oh, we have quite a few misconceptions, I think. Predominantly what we do, we don't just touch feet and we don't have weird foot fetishes. Believe me when I tell you that. It's probably my most regular question. Why feet? What are you doing feet for? Well, it's not just feet, it's the whole lower limb, and we're not just cutting nails, debriding callus, enucleating corns and dealing with high risk diabetic wounds. The service that we're offering here and my subspecialism is musculoskeletal. So I think the misconception is that we just see little old ladies and debride their callus. We are kind of experts in lower limb biomechanics and managing pain in the lower limb as well. So I think that's one of the misconceptions, that you can't come and see a podiatrist for a lower limb musculoskeletal pain issue. That's exactly what you want to come and see a podiatrist for, and that's exactly what I can help you with. So there's probably no 2 assessments that will be exactly the same, because I mean my particular approach to this is that it will be skewed and sort of individualised to you and your complaint and what you're coming in with, really. But as a sort of general rule, the first thing that we want to know is get a real thorough history. I want to know who you are, what you've been doing, what you want to be doing, and what your problem is essentially. So moving on from that, then that'll inform all of my subsequent assessments. So we'll start to look at what's going on in foot and ankle, how those mechanics can then influence perhaps some of the function higher up the chain, so within the knee, within the hip. This might be sort of on the chair, so what we call non-weight bearing assessment. I'll be prodding and poking you and pulling you around. I'll be getting you weight bearing, doing some simple movements, some functional things, looking at your capacity, looking at your tolerance to pain. We'll be assessing range of motion. I'll be looking at you walking where it's relevant. I'll be looking at you running, and in sort of the gym-based session, if that's what you're doing, then that's what I want to see you doing. So I might get you squatting, I might get you deadlifting. Whenever you're getting your pain, well, I want to see that pattern, I want to see that movement, and then that's how I can work out how to get you better and what aspects we can modify, because that's what I want to do. You're not broken, you just need a bit of fine tuning, and that's what my job is, help facilitate that. So sometimes we will give insoles, sometimes we won't give insoles. Again, this depends on what our assessment yields. And from my experience, it also depends on what the patient wants. If you're sitting there telling me that you're not keen on that and that's not really what you want to try first, then cool, that's not what we'll try first. We have a big tool bag of kind of interventions, so we might go down our kind of exercise route to begin with. As a general rule, for most sort of problems that people come in with, whatever I do with an insole, I'll look to kind of concurrently mimic that with active therapies alongside. So in a lot of cases, there will be some benefit from insoles. And it might be that we just see that as kind of a temporary intervention. It might be a more sort of mid to long term intervention, but it will be entirely dependent on our assessment and sort of needs based essentially. And that's what I'll be looking at during my assessment. So I think what stands us apart here is that we're all about you. We're not here to necessarily make you better because you're not broken. Yes, you've got pain, you've got problems, that's why you're coming to see us, but ultimately you're going to get you better. We're here just to facilitate that. I'm going to give you the tools to get yourself better, and that's what it's all about. Like, you know, I can't wear insoles for you, I can't do the exercises for you, but I can give you those tools and then you can do it, you can get yourself better. And that's my job, for me to kind of empower you really, and I think that's an element that sort of stands us apart. In terms of the podiatry specific stuff, the way that I tend to practice is I will look at insoles always as a first line, as a temporary intervention. So I'll make something chair side, we'll try it. It lets me work out effectiveness, it lets me work out tolerance, and it lets me work out accommodation in footwear, and then I can use that information upon my review to inform my next steps. So it works diagnostically, it works prognostically for me, but this isn't I need to fix you because your biomechanics are all over the place. I'm a fine tuner, so that's what I'm looking at this through the lens of essentially. I'll put this insole in, I'll tweak the mechanics, and that might just be a short term, give you enough of a window to let things heal, to let our exercise interventions start taking place. We get that tissue change, we get that capacity increase, great. Insole wears out, your symptoms aren't coming back, wonderful. We don't need to consider that as a longer term intervention. In some cases, we might get a bit better but start to plateau, great. Well, then we can look at insoles as a longer term intervention. So this isn't a, you come to me, I'm going to sell you expensive insoles, Jovie, and tell you all the reasons why you need them forever, because that is very, very rarely the case. And I think that's what stands us apart. Absolutely. In my career, I've often been involved in multidisciplinary work, and lots of research says this works best. So, you know, you get different specialisms, and physios are obviously specialist clinicians, podiatrists are specialist clinicians. We have different training, we have different perspectives, so we can look at the same thing through different lenses. So if you want to get better quicker, then you know, two minds are better than one, two professions are better than one. So we work sort of hand in hand. We are not rivals working against each other. So absolutely, we're very keen on sort of multidisciplinary team working and inter-referral between physiotherapy, podiatry.